The following content is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition.
Hello, and welcome everyone to Always Another Way podcast. My name is Marina Sprocki-Spriggs, and I am your host. I have a master's in professional counseling. I am the IPPY Award-winning author of Stop Looking for a Husband, Find the Love of Your Life, A Nasty Divorce, A Kid's Eye View. I write positive divorce advice for the HuffPost, and I'm trained in clinical hypnosis. And this podcast speaks to out-of-the-box thinkers, and it's for those who hear the call of hope and always another way. And if you're very rigid and set in your beliefs, this is probably not your cup of tea. However, you should note, taste can and do change. And today, I don't know if you're somebody that thinks about dying or not. Maybe depending on what age you are, if these things come around. I guess I don't like to think about it, and probably most people don't. But just sometimes maybe like in the existential way, like I like to think about, oh no, what if I only have like this much time left? How am I going to use my time? Or, what do I want my purpose to be, my legacy, things like that. But as we get older, and all of those of us and you that are lucky enough to live a long, healthy life, it is going to come to an end one day, just because it does. And maybe you know, or maybe you don't know, but you do have options. Or maybe it's something because a lot of people don't like to talk about it. They don't like to think about it. And then you maybe end up in a little bit of a pickle later. So I'm here to tell you that you are in control of your medical choices. And my guest is Dr. Sam Harrington. He is the author of At Peace, Choosing a Good Death After a Long Life. And we had him on a couple months ago with a very, very informative talk about his book. And today we're going to bring him back on because there is so much more to talk about, from just the theoretical, but into the more practical. So I want to tell you a little bit about Dr. Sam Harrington. He grew up in Milwaukee, Wisconsin, an honors graduate of Harvard College and the University of Wisconsin Medical School. He practiced internal medicine and gastroenterology for more than 30 years in Washington, D.C. There he served on the Board of Trustees of Sibley Memorial Hospital, a member of the Johns Hopkins Health System, and the former Hospice Care of DC. As a clinician in private practice, Sam served a wide range of patients from the indigent to those working at the highest levels of government. As a medical staff leader, he worked to improve the quality and advance patient safety. So, welcome to the show again, Dr. Sam Harrington.
Marina, thank you very much for having me. I'm looking forward to speaking with you again.
Yeah, great. So we talked about quite a bit, and it was super informative last time, but I know there's just so much more because it's not really a widely talked about subject, and then other than your book, just not a lot of places where you can get good information like this. So I'm just going to kind of let you start and bring us in, from your father's vision, and we'll just kind of go down the list of things that people need to know.
Okay, well, for anybody who listened before, I will repeat or those who hadn't listened, I will start by saying that my father expressed a vision to me and my sisters when we were discussing repairing an abdominal aortic aneurysm, a blood vessel that was large enough to be threatening to rupture, and that would be a fatal event. And yet, and at age 88 and in good health, he surprised us when he said something to the effect of, Sam, why would I want to fix something that is going to carry me away the way that I want to go, quickly and decisively? And that was an informative vision of how he was thinking. And in a sense, that was the beginning of what's called the hard conversation, end of life discussions. But he had, of course, what's called an advance directive in place. That's a written series of papers, sometimes referred to as a living will. And so I thought I would discuss how advance directives work today and how a vision fits into the process. So the overall concept of advance directives falls under the umbrella of something called advanced care planning, and it consists of several factors. It consists of the identification of a healthcare proxy or power of attorney. That's the person who speaks for the patient when the patient can't speak for themselves. And to designate that person is a legal undertaking that requires some paperwork, usually with a lawyer. Then there is the living will, which is another series of documents that outline the patient's wishes. And then there is every conversation that takes place that includes end-of-life thinking, such as the conversation my father and my sisters and I had about his aortic aneurysm. And all of these have to come together to help patients achieve their end-of-life wishes. Now, my book relates almost exclusively to elderly patients because I think it's important that elderly patients are not subjected to futile care. But some of the comments I make today would pertain to younger patients. But keep in mind that I'm really focused on elderly patients, people over the age of 65, according to the CDC, and I'm over 65, but really people who are over 85 or 75 with a chronic illness, and people and the children who are helping them make decisions. So in choosing a healthcare proxy, the most common thing is to select somebody in the family, usually a spouse, or if no spouse is alive, then the oldest child or some member of the family with medical knowledge. But the most important factor in my mind in choosing a proxy is to choose somebody who can speak with the patient and understand the patient's wishes, and then translate those to the family so that there's a consensus in the family. Because a family that works together is more likely to have the elderly patient's wishes understood and achieved. And we have to keep in mind that 80 or 90% of elderly patients express a preference to die at home as quietly as possible, and yet 60% of elderly patients die in hospitals and institutions because they haven't made the proper plans to be prepared to say no to hospitalization at the appropriate time.
Wow. So let me ask, so if you have no plans, then you're just kind of at the mercy of what they're going to do.
Once you go to the hospital for any reason, one tends to, treatment is almost always initiated, and it is harder to stop treatment than to avoid starting it. And once treatment is initiated, there's a momentum to it that carries the day, and patients who think they're going to go to the hospital for something brief or because their caregivers are frightened that something treatable has happened, they get to the hospital and treatment is started, and frequently the patient is too weak to speak for themselves and their proxy has to step up to the plate.
I see.
But the goal is to avoid that, if possible, through better decision making. And so for example, when my father advised us about his vision of dying quickly and suddenly from a ruptured aneurysm, that was a naive comment on his part, but it informed us, myself and my sisters, that we were to seek out, if we saw another similar opportunity where he could receive palliative medications and die quickly and comfortably, then we were to take that opportunity and not let him endure prolonged treatments and prolonged debility. And we have to keep in mind that what the proxy says or what the patient says is supersedes anything that's ever been written. If they say it at the time of treatment. So if a patient had said, I don't want a feeding tube, and then at the time of treatment they change their mind and say, I do want a feeding tube, or the proxy says, I want my parent to have a feeding tube, then that is what takes place.
Ah, I see.
And because sometimes people think that means, well, if the proxy or the patient speaks and their final decision is final, what does the paperwork have to do with this? Why do we have to have a living will? And there are several reasons to have a living will that are critically important. Legal people, lawyers, look at a living will and say, well, the living will be used in case of a legal arbitration. If the hospital takes one position about caring for a patient and the patient's family takes another position, the living will be the final arbiter as based on the patient's wishes is what should happen. And so a judge in a courtroom might adjudicate that, or a doctor in a corridor might make the decision. But that's a very rare situation compared to all the other times when people are in a hospital and need emergency care. And so under those circumstances, doctors don't parse the living will. They treat the patient until they have time to pause and then consider what the living will says. So when a patient comes in, if the family is in consensus to say, okay, make her comfortable. This has happened. We don't want aggressive treatment. Please make my mother comfortable. The doctors will do that. If the family is divided, if the proxy says, make this woman comfortable, and the family member says, no, you have to treat her aggressively too. You have to save her life. Then the doctors will be in conflict. And even though the proxy has said, simply make her comfortable, the doctors are likely to delay that comfort care and promote treatment until an agreement can be reached between all parties. So it's important, again, to have the living will to kind of adjudicate that, but it's more important not to get in that position and to have everybody agree in principle.
Right.
The other two reasons to have a living will are that it serves as the foundation for the discussions that occur between family members and the patient and doctors. And so if you were to download, let's say, the typical state, you're in Texas, I think,
Texas,
I'm in Maine.
Yes. Mm-hmm.
If I download the Maine state living will, which is considered adequate, it comes up with 3 questions and 2 scenarios. The 2 scenarios are what to do in the case of a persistent vegetative state, where the person's partially brain dead, but their brain stem is still keeping them breathing and their heart pumping. Does that person want life support? Does that person want a feeding tube? And the other scenario is what to do if a person is terminally ill as dictated by 2 physicians or as determined by 2 physicians. And does the patient want life support as long as possible, or does the patient want tube feeding? Well, filling that form out takes a matter of minutes, but it's also woefully inadequate to deal with patients who have other medical illnesses and other thoughts about what to do at the end of a long life, because some patients will not want to prolong their death. Other patients will want to hasten their death, and we have to respect that perspective also. and I'll get back to that later if we have a chance, but I want to mention the third important role of a written living will is that a proxy who ultimately has the decision power to either figuratively or physically pull the plug, meaning end life-sustaining treatment, needs all the support that's possible to make that decision, because it's from an intellectual point of view, we may prepare ourselves for that, but in an emotional point of view, it's very difficult. Oh, right. And having the piece of paper that everyone has discussed and that supports that decision supports the decision maker. And it has been shown in medical studies that families who have well-defined living wills suffer less stress, less grief, less depression moving toward that decision, and they suffer less stress, anxiety, grief, and depression after the death. So it's not only good for the patient, it's good for the family. It's a gift to the family to have a good living will.
Yeah, that sounds like, and especially since you said like 60% of people just end up not getting a choice, that's a very large number. It's a good reason to do that kind of stuff.
Well, and comparatively few people have filled out a living will in America. I mean, some people quote as little as 30% of people have a living will, and it's really critical that we increase that number. And a few minutes ago, I said that the typical boilerplate living will is quite inadequate, and that's because it doesn't address more subtle things. Yes, it says, do you want a feeding tube? Yes or no. Do you want a breathing tube? Yes or no. But it doesn't address concepts like quality of life versus quantity of life. Mm. It doesn't address the distinction between prolonging life and prolonging the dying process. It doesn't address the typical boilerplate living will, doesn't address the critical understanding that patients should have that to decline treatment and to withdraw treatment are morally, legally, and ethically equivalent, even though it is somewhat harder emotionally to withdraw treatment than to decline it in the first place.
Yeah, I bet.
And we have to remember, I think a living will can remind us, as in my father's case, that withdrawing or declining treatment is a way to assert control at the end of a long life. And control is one of the most important things that people can, most of the important attributes of a good death or a better death.
Yeah, and then where else do we kind of go from here?
Well, I think I'll add two more points about a living will. I think that living wills should also address a transfer clause, so that if a patient is stuck or is put in a hospital on an emergency basis that for moral or religious reasons doesn't want to honor that patient's living will, their agent should have be guided to transfer the patient elsewhere. And it should also have a dementia clause, which most people don't put in unless they have dementia in the family.
Oh, wow.
But a dementia clause would allow people, would allow the proxy to restrict medical care as dementia advances. So that if a patient is mildly demented, they might say, I want my proxy to make me a do not resuscitate patient. If the patient is moderately demented and, for example, uses a guideline such as I can't dress properly for the season, or I put my keys in the microwave, then I want my proxy to restrict antibiotics, or I want to advise that I want no heroic measures. And then if a patient becomes severely demented, as measured by, for example, the inability to recognize their family members or being bedbound, then I think that one might say that one might ask the proxy to define manual feeding as a medical treatment, and any medical treatment can be denied or declined, I should say. So the proxy might be required to put a tray of food in front of the patient for 3 times a day, but not put a spoon to the lips or a straw to the mouth.
Interesting.
That kind of thinking. That's the kind of thinking that I think should go into a powerful living will. So as a gift, as I say, to the family and to the friends who are going to be dealing with this.
Right, because you wouldn't want to end up with, if the person has dementia, and then if they say something, does then the doctor have to listen to their words with dementia if you don't have that?
Not with a demented patient.
Okay.
The doctor then has to live. I misspoke. If a demented patient is still legally competent, yes.
Okay.
And in early stages of dementia, that is the case. But in the later stages of dementia, the patient cannot speak for themselves, even if they can mouth words.
Okay. Just checking.
Right, right. So there are 2 other things that I think probably should be brought up within the construct of a discussion of advanced directives, and these fall outside of the living will, but one is a do not resuscitate status. I referred to that. And the other is something called pulsed orders. And I think pulsed orders are the single most important development in advanced directives in the last 10 years. They've been around since the late 90s, but they have not gained traction for a long time. So let me address do not resuscitate for a minute, and then pulsed orders. Do not resuscitate orders are something that people should consider at an advanced age, simply because CPR, cardiopulmonary resuscitation, is not very successful, despite what we see on television, and it is brutal in terms of treatment because it crushes the sternum, breaks ribs in elderly patients. So in the unlikely event that an elderly patient survives CPR, they will live for weeks, if not months, with broken ribs and in great pain. My father decided at age 89 that he would be do not resuscitate status, even though he was seemingly healthy, because he understood what I just described, and because he deemed that an exit strategy similar to letting his aneurysm rupture. If he collapsed from a heart attack and his heart stopped, he just didn't want to have any resuscitation attempts, in much the same way that if his aorta ruptured, he would want palliative treatment. And he saw this as a way of asserting control at the end of his life and not becoming dependent or suffering futile treatment. So pulsed orders, this is critical. Pulsed orders are that's an acronym for Physician Orders for Life-Sustaining Treatment. And the difference between a pulsed order and a living will is that a living will is aspirational. A living will is what the patient wants, but it's not signed as an order by a doctor, whereas a pulsed order is signed as an order by the patient's primary doctor, so that patients who are in a sort of a limbo, that is to say, patients who are either nursing home bound or homebound, they suffer from the advanced age and a chronic illness, and rely, but they're not sick enough to benefit by or be allowed into hospice care. This group of patients might want to avoid heroic measures. So if a nursing home patient has a stroke and goes and is taken to the hospital for treatment, if they have signed pulsed orders in advance after discussing it with their doctor, they can say, I've had a stroke. The post orders can indicate in the event of a stroke, make this patient comfortable, treat their stroke, but do not place a feeding tube, do not place a breathing tube. These are restrictions that should not be done. And because they're written as an order, the emergency room doctor who receives the patient and the intensive care unit doctor will not immediately introduce that kind of aggressive treatment. They will immediately start supportive treatment and then discuss things with the family. So the post orders are a way of standing between emergency care and palliative care in that small group of patients, or not so small, in that group of patients who are sort of in a pre-hospice care situation. And in Texas, I know that post orders are not well established. I'm going to the pulsed.org website, indicates that Texas is one of about 11 states or 8 states that have pilot programs for post orders. So if you're listening in Texas and you think your parent would benefit by this kind of order, you have to go to your physician and inquire if they can be part of this pilot program. In other states, about 22 states, post orders are considered mature. That means that that every EMT in the state and every emergency room will recognize these orders when a patient is brought in from home or brought in from a nursing home with this order set in hand.
Oh, that's... And then... Oh, sorry. That's interesting that you needed to, like, you couldn't just do it anyways just ask a doctor to write up when it has to go through the pulsed thing.
Well, it has, right. The state has to, well, you know, I don't know. Maybe a doctor could do that. It hadn't occurred to me while I was in practice. The issue didn't come up. Post orders were not available in Washington, D.C. when I was in practice. But now I think that they should be, and I think that every responsible physician should be discussing this with their patients.
Yeah, that's good to know. I did not know about this.
Yeah.
Okay, so they've got, you can do the living will, the post orders, a DNR, and what are some other things, other choices that people have?
Well, some people choose to hasten their death. This is comparatively uncommon. The most common approach would be simply to decline treatment. That's sort of my father's approach. Another approach would be to stop eating and drinking. This is voluntary dehydration. We discussed that last episode. And then another approach is to take advantage of medical aid in dying, which is the Death with Dignity program that allows patients in 8 states and the District of Columbia to take a lethal dose of medicine. But it's quite a complicated process. It's actually, I shouldn't say it's complicated because it's pretty straightforward, and yet it's complicated enough that comparatively few people actually avail themselves of that. In the District of Columbia, I was in communication with the officials monitoring this in DC, and after 18 months in DC of the availability of medical aid in dying, not a single patient had signed up for it.
Oh, wow.
So that's...
Is there just a lot of hoops to get into it? Like, do you have to qualify like in a certain way?
There are some hoops, but the vast majority of people would already be in hospice or approaching hospice care under those circumstances. So the general requirements for, and this is a general summary for the 8 states, is that 2 physicians have to certify that patients are terminally ill. The patient has to have a waiting period between physician consultations and receiving the medication so that they have the chance to change their mind. And when they receive the medication, they are allowed to take it at any time they wish, so they can take it home with them. But then they have to be mentally competent and physically capable of self-administration. So many people will start the application process and then get to the point where they aren't mentally competent themselves, in which case they can't take it, or they physically can't take it. And I think that I was very interested when I started looking into this, that in Oregon, where medical aid in dying has been available for more than 20 years, less than 0.5% of people for whom this is available actually take the medication. So if 10,000 people in Oregon are dying of a chronic illness and could avail of themselves of this opportunity, 39 out of 10,000 actually do, which I find is a stunningly low figure.
Yeah.
And says to me a couple of things. First of all, if you want to use it, you have to think about it even harder than simply writing a living will and doing the things that I've recommended. And that the will to live is so great that people delay the process so long that they really can't physically lift the medication to their mouths or aren't competent at that point, which I understand. That's not a criticism. I just think it's an interesting observation that people fight for that right and then
don't take it when it comes down to it.
Then can't use it. Yeah. So
yeah, that's very, very interesting. I've always wondered that kind of too about, maybe I guess I didn't know that many states that they had that option, but then that's interesting that just nobody took up on it in DC too. So yeah, maybe when the rubber hits the road, good to talk in theory, but then when you're faced with it, I wonder if there's still that last hope, I don't know, maybe it'll turn around.
Maybe I'll just get better.
Yeah.
And who knows? We never know how we'll approach our own deaths. I recognize that I have studied it and thought about it a lot, but who knows how I will face my own crises or how my family will face them with me. All we can do is the best we can to try and make things work out.
Yeah. And so what if you had to give maybe just 2 more things that you think are just important to tell people?
Well, I think that it's important. One thing I'll say is that I think that it's important to study one's prognosis. This is something that people ignore, people avoid. And I think that it really hampers the decision making. Of course, it's upsetting to hear that one has a certain median life expectancy, but if you don't look into that, you can't make very good decisions. When my mother was 82, she was diagnosed with stage 4 lung cancer. And she left her doctor's office. My father had gone with her, and she didn't really understand that she was terminally ill. And I was somewhat taken aback. Now, it might have been that the doctor tried to talk about it and they didn't want to hear it. I don't know. But in any event, when I went out to chat with them about treatment options, I explained that her median life expectancy was 10 months. And it was a very difficult conversation, but it had to be done. And ultimately, when she understood that, she was able to say, I'm old and frail, and I'm not likely to make it to 10 months anyway with this diagnosis. That would be something that a younger person would achieve who could withstand more treatment. So I'm going to focus on other things in the near future and hope to survive long enough to benefit there.
Right. And those are good things that you would hate to not think about that and then just kind of waste your time
if you don't
worrying.
think right, and doctors, as I just said, doctors tend not to look at this with a hard-edged focus. There was one study that I really was interested in on prognosis, whereby physicians were asked how long they thought their patients would live after they were accepted into hospice care. And 20% of the doctors were correct. Roughly, they thought, well, this patient will probably live 3 months. 20% of them were accurate. And 17% were pessimistic, meaning the patient lived longer than the doctor expected. I recognize that I'm a pessimist in this regard because some of the life that people have, I think, is so difficult that I feel sad for them that they're suffering so much. But anyway, I'm a pessimist.
Yeah.
And then 63% of doctors thought that their patients would live 5 months, and those patients died within a month.
Huh.
Meaning they were overly optimistic by a factor of 5. And it's important for doctors to know whether they're optimists or pessimists, but it's also important for patients to understand that doctors are systematically optimistic. And if they're destined to live a month and doctors think 6 months or they will live 5 months, they're less likely to put them in, offer them hospice care, and they're more likely to offer them treatment that's not going to work. So it's important to look at our prognosis and look at the filters through which that prognosis are offered to us.
And then I wonder that, and then you just end up with treatment and spending money that's just not going to work out anyways in the long run.
Right, and money aside, futile treatment is physically cruel and morally wrong.
Yeah,
and
I agree.
If we know we're treating somebody and they're not going to get better, that is almost criminal in my mind.
Yeah, I agree. And then just quality of life, that if you could do nothing, not be in a hospital, you could spend that time doing what you want with family and friends. But once you get in there and hooked up, then things can just go sideways really quick.
Absolutely. Absolutely.
Yeah. Ooh, good advice. Good advice. Yes. Okay. One more or anything else?
Well, I have nothing. I have one more point. My summary is that 80 to 90% of patients want to pass away comfortably at home. And if you want to help your loved one do that, you have to help them understand when to say no to hospitalization.
All right, that sounds great. And definitely get Dr. Harrington's book, At Peace, Choosing a Good Death After a Long Life. It is just really chocked with all sorts of information, answering a lot of questions. And you're right, if 80 to 90%, and I think just probably everybody's like, yep, I like to die at home in my sleep. That sounds good. But to then talk about it and then to have so few people really do anything, there is that gap there. And there are many things that can be done to allow you to have that control. You can't predict, but you could get closer to that. Exactly.
So if anyone wants to contact me, I'm at samharrington.com, and the book is on Amazon. And I appreciate the time you've offered, Marina.
Well, thank you so much. I appreciate you being on. You know where to find Dr. Harrington. And for everybody listening, there is always another way.